the best medications in mental health today, at best, help 20% of the people who take them. No one so far had framed psychedelics in a risk and cost framework. When you talk to establishment healthcare figures at payers, and the P word comes up, the meeting may as well be over.
Welcome to the Mental Health Coffee Break, a podcast where we slow down just enough to have thoughtful conversations about the people, ideas, and systems shaping the future of mental health. This season is about pushing boundaries and few areas in mental health and behavioral health, or pushing boundaries with perhaps more controversy than psychedelic-assisted therapies. For decades, these treatments existed sometimes at the margin of medicine and public conversation. Today, they are re-emerging through clinical research, evidence-based models, and serious discussion around outcomes, access, and long-term behavioral health transformation. Our guest today is Josh Stevens, CEO of Beckley Clinical, a behavioral health provider focused on drug-assisted therapies and evidence-based psychedelic treatments, with a particular emphasis on value-based care and improving outcomes for patients. Josh, thank you so much for joining me today on the podcast.
Pleasure to be here. Great to be here.
I'd always like to start with something very simple for our listeners, especially for people who might have heard the terms psychedelic-assisted therapies or just psychedelic in the media, but don't fully understand what it means.
Sure. So we, the P word, psychedelics, we actually don't amplify that word. So we say we do rapid acting interventional psychiatry.
Okay.
It's rapid acting. Things that we do work relatively quickly compared to the standard of care. It's interventional because we're working intensely with patients over a period of time. And it's value-based, meaning we get to an outcome that is lower cost than trend and better outcomes than expected.
Can you just tell a bit more about, again, for people who might not be aware of that, what kind of conditions does that usually treat?
So the primary conditions we're focused on, we'd say garden variety behavioral health, anxiety, depression, PTSD are really where a lot of the volume is in the field. In addition, we will look at bipolar, and we'll also look at addiction and recovery cases.
Okay, very interesting. I want to go back to the P word, as you said earlier, and knowing that it could be a controversial word from time to time with some people, and including patients or clinicians. How did you manage to reframe the conversations towards a more a conversation that is more grounded in research and clinical rigor?
Well, look, the clinical rigor and research around psychedelics, what we now call psychedelics, really started in the 1960s at some East Coast and West Coast universities that you've heard of, and continued on really into the early 80s until it was shut down by some partisan policy that was more politics than science.
Okay.
And that has been it's reemerged in the last 10 years as a lot of continuing research has happened with exceptions from the federal government to allow it to continue on a limited basis. And the impact of these compounds is so extraordinary that it took some time for an administration, and it happens to be the current administration, to say it's time to really take the lid off of this and reintroduce this into the mainstream because there's potential here. I'd also offer that the P word is something that we've learned, and I learned this the hard way as someone who was not educated or schooled in psychedelics as a young person. I was psychedelic naive, as folks in that community will often refer to it.
I think a lot of us are.
I think coastal elites are less naive than we think, but I think that most average folks have not necessarily experimented with psychedelics, including myself. And I would say that when you talk to establishment healthcare figures at payers, and the P word comes up, the meeting may as well be over.
Yeah.
If you ask to have a meeting to discuss psychedelic therapy, you won't even get the meeting. It's there's curiosity. It's almost like an animal in a zoo to people who are in the establishment, but they're so removed from the current science and the current work on it because it's not their job to focus on those things.
Yeah.
That there's a lot of perception that really lags the reality of the impact of the compounds. If we reframed this to say, well, we asked, well, what is it that you actually are interested in? Because I think whether it's anything in business or in social matters, understanding what your counterpart is interested in helps a great deal to frame any conversation and to be heard. And what we heard were the most obvious and yet most unexpected responses, which were risk management, cost management, full stop.
Okay.
Now, there's a lot of other things that payers could do or that we think healthcare institutions want to do, but they're insurance companies, and they're fundamentally driven by managing risk and cost. And no one so far had framed psychedelics in a risk and cost framework. So we thought, well, this is something that we've done before with prior companies. And my next phone call was to an actuary. And actuaries tend to be the greatest whisperer to payers. Because this is how decisions get made. Is there an actuarial analysis that will show a healthcare executive who's going to take risk on a cost he or she will incur, that they will not lose money for the company? And no one had ever presented an actuarial analysis of psychedelics to a payer, as far as we can tell.
Actually, linked to that, when we initially talked, you used a term I thought was funny. You said that your approach to that topic specifically is a boring approach.
Well, yes.
Can you tell more about that?
Most successful approaches in healthcare are extremely boring. And that's something that we're very proud of, adhering to that truth, because no one makes, going back to how decisions get made. United Healthcare and Cigna and Blue Shield of California, HCSC are not going to make decisions because something is cool or because it's fashionable or because it's interesting to the chief medical officer. Ultimately, it's going to come down to a multi-party conversation because Ken Goulet is an executive who, well-known exec from Cigna, now retired, and we attribute this quote to him, one of the most successful Cigna execs of all time, maybe insurance execs of all time. He said, when you want to work with a payer, 13 executives have to say yes to a decision. And, the actuary, the chief medical officer, the P&L owner, the product owner, and on, the compliance person, the safety person, and no one of them, they all have to say yes. No, any one of them can say no. If one of them says no, then you have no deal. But all of them have to say yes for you to get your deal, or at least not object. And so really understanding that is the lens at which, first of all, it's group decision-making. And second, it's about risk and cost. Then we said, okay, well, how do they make these decisions? And they said they look at the analysis of, will they have better outcomes at lower cost? And I'm not even sure, and I don't say this to poke any payer in the eye, I'm not even sure that the outcomes are what they're focused on. It's really the cost. As long as their cost is coming down, because unlike in France, where people could be in one insurance pool for their life, here the average tenure with a payer for an American is 2 to 3 years before they switch to a different payer, usually because they switch jobs. And so since employer-based healthcare causes people to go from one payer to another, the payer is concerned with how much risk and cost they will take over those 2 to 3 years. If someone is going to have a problem in 5 years, they really don't care about that because that's the next payer's problem. And so there's not it's a bit of a moral hazard and a structural problem of our system, but we have to be honest about it in order to make effective progress with payers and say they're focused on 2 to 3 year windows. They're focused on risk and cost. Everything else can take a walk. So this might seem boring, but it's effective.
But it's also very interesting that, as you explained at the beginning, that you managed to talk their language, and in a way that was sort of the key to.
Well, I'm old. I've been working. I'm in my 50s, and I started this a long time ago. And population health, I learned started in 15 years ago when Obamacare was coming in becoming law. And learned how to work with payers then. And it was a real education because I was in tech from Silicon Valley and thought that if we had great tech, it would be immediately adopted by the payers and we'd be heroes for helping smooth the administrative burden of healthcare. And what I learned was, as everyone already knew, insurance companies aren't really technology early adopters, number one. And number two, they have no incentive to take risk. Their job is to manage down risk. And so new vendors, new approaches, new things, it's all very scary for payers. So we have to make it not scary for them by speaking their language.
The first thing that attracted me when I looked at the company, because I had never seen that anywhere else, is your approach to value-based care within that field specifically. Can you tell us, one, what's your approach and why is that unique?
Well, our approach is ultimately to be fully at risk, to take full risk on the cases that we manage, to get folks better at a lower cost. And this is, as far as we can tell, unique in the market. It's not common for behavioral health providers to take risk. It's unheard of for behavioral health companies to go full risk. I mean, they'll take all the risk. And there's two structural challenges that I think have prevented this so far. The first has been an access problem, and the second has been a tools problem. Look at the equation we have to work with. The tools don't work very well if 1 in 5 gets help from pharmacy. Therapists are not easily available under insurance to most people in most towns in America. And the rate of remission of who gets better right now is about 7%. So this is really a messy situation that is ripe for some innovation and disruption. But of course, we can't say innovation, disruption, or psychedelics with a payer. We would just say we have a better way of getting at risk and cost.
I love how you master the language. There's one aspect that you actually briefly mentioned regarding value-based care, which is measurements. And usually when it comes to behavioral health, there's some critics around the difficulty to measure impact in a consistent way. In your case and the case of your business, what metrics matters the most?
So the one metric that rules them all from the Beckley perspective is sustained remission. So you can be diagnosed with anxiety, depression, PTSD, but as we were talking about, 7% actually get better on average. 93% never get out of their condition. They carry that condition to the grave. They may get a little better with a medication, or they might get somewhat better with therapy, but in the end, 7% who are diagnosed have the diagnosed removed from their record in their lifetime. This is an opportunity then to say, okay, well, then how are we tracking remission? Well, first there's a diagnosis, and then is the diagnosis removed from the record? That's a simple way to track, and maybe the most binary and easiest way to track, because if it isn't simple and easy, it's not going to be measured, and if it's not measurable, it can't be managed. So we said, if you really cut to the last page, remission is the goal. And remission for a day is not interesting, but remission for a month is mildly interesting. Remission for a year gets kind of interesting, but remission full stop, sustained remission for life is really where the game is going to go. And this is our ultimate North Star and our key measure. So when we take in a patient and put them through interventional psychiatry, they have a diagnosis and they're going to get treated with an intervention. As that intervention proceeds, typically patients will have abatement of symptoms. They'll go from severe to moderate, which is a specific diagnosis indication on the scales, the GAD-7, or the DSM-5, for example. So we'll have tracking along the way that are accepted, objective scales taken by the provider and the patient together. Then, in addition to this, there's looking at cost. Did we take them off of expensive medications? That's a measurement. When we can show a payer that not only did their scales get better, that their GAD-7s and PHQ-9s went from severe depression to remission, but also that their on-patent prescriptions that were not helping them went from $40,000 a year to zero. And we can show them that they've also returned to work. That's another SDOH measure we could show as an additional measure, but it all really revolves around remission. Did they get better or not? And so remission is the goal. And if not remission, it's abatement of symptoms, abatement of diagnosis, from severe to moderates, moderates to milds.
And what has been the reaction of payers so far?
Well, I think it's been good. they've been usually shocked because nobody talks to them this way in terms of behavioral health, saying, I've got something that works and I'll take risk on it. That's a new idea in behavioral health. It's been around in surgery for a long time, of lowering risk and cost of surgery or of knee replacements or hip replacements. It's been around in diabetes a little bit and metabolic health. It's really new to behavioral health. So it's exciting to hear, but we don't come in with guns a-blazing and very flashy. We really just start with, we understand this is a high cost, a high risk problem for your balance sheet. And we have a way to help arbitrage the risk and cost and serve patients better. And so, but I mean, in terms of measurement, I think anyone who says you can't measure behavioral health is dreaming, because I'd say there's 5 areas we could look at broadly. The scales that patients take, meaning the GAD-7, the PHQs, the scales that providers provide, the HAM-D and the MADRS. So there's those. There's the pharmacy cost going down over time. That's easily measurable, and payers love this. There's the medical cost coming down. Did the emergency room or emergency department cost from last year to this year go down or go to zero? That's important. There's quality measures under HEDIS, CAPS, and STARS that everybody cares about, especially payers and hospitals. And then there's compliance, of course, where things done properly and to code, especially if you're dealing with controlled substances. So we can track all 5 of those categories, and that's what we're showing in a scorecard to payers to say, look, if you're serious about getting somebody better, how could we know if they got better if we didn't track all of these things? So we have to do it to do the work. We're happy to put a report together for a payer.
And there's one thing you said that is that I found interesting, and I'm curious to get your view on that. You mentioned the fact that when you go to payers with all this evidence and this approach, they almost shocked because they've never seen that before. Do you think they are other part in healthcare that have the same issue, where it's just about people who are entrepreneurs who are not, able to talk to payers with their language?
Yes, there's a myth in the marketplace, I believe, which is that payers are so closed and hard to deal with. I think this is a complete myth. I think that payers have always been open. It's just a matter of, do you know what's important to them? And do we know how to talk to them about what matters to them? And this is where it is a bit like dating. You have to know your audience and know how they want to be approached. And if you don't approach them in a way that they're comfortable, then it's not going to work. So payers have always been open, in my view. I just think that we've underestimated the payers to move very quickly if we could actually deliver what they care about, which is risk and cost.
So I always like to finish this podcast with a French tradition called the Proust questionnaire.
Formidable.
So I'm going to share with you some short prompt, and you have to reply by a word or a very short phrase.
Okay.
One word that captured the state of mental health innovation today.
Disrupted.
One quality every mental health founder must embody.
Conviction.
Evidence-based care becomes powerful when
It's measured and managed.
the future of mental health treatment is
The future of mental health treatment is the end of chronic condition behavioral health as we know it.
wow. Very that's a beautiful, optimistic view for the future, like that.
Well, Proust is a beautiful literary figure.
You stayed in theme. Well, thank you so much for joining today.
Thank you very much. It's great to be here.
This was the Mental Health Coffee Break, a conversation about technology, care, and the future of mental health. Until next time, take care of yourself and take care of one another.